Techie. Right, ready to go live. My name is Miranda van Dam. I am the chairperson of the AXPAR Association, a support group of patients with AXPAR in South Africa. The Voice of the Patient and Expert is a program designed to bring not only live witness, but also to educate and support you at home. Tonight, we welcome Corne van Eck. Corne has her own practice in the garden route, gaining international experience in the US for many years. She has written a number of publications and is the author of many educational courses. Through the years, she has been a guest speaker in areas covering lymphedema, the lumbar spine, the cervical spine, and peripheral edema. Corne is furthermore a member of the South African Society of Physiotherapy. She's a fellow of the American Academy of Orthopedic Manual Physical Therapists. She's part of the Lymphedema Association of South Africa. Corne and I met many years ago when I had my initial symptoms of AXPAR. Welcome, Corne, this evening, and for your time and effort to prepare your presentation for us. Welcome.
Thank you, Miranda. It is a privilege, and congratulations to you for taking something from nothing and making it a wonderful dream come true for many of the patients that share your symptoms and share your diagnosis. You've really done a good job. So congratulations to you and your team.
Thanks for the kind words, Corne.
So tonight we're going to talk about axial spondyloarthritis and movement, improving your quality of life. I am Corne van Eck and I am a physiotherapist. Improve your quality of life through delaying the progression of AXPAR and Ankylosing Spondylite will be the focus of tonight's talk. Why are you here? And why are you watching this presentation? Can you associate with this gentleman? Do you have neck pain? Are you constantly aware of your neck? Can you associate with this lady? Do you have chronic pain? Are you in a dark place? Or is your head in your hands? Are you always aware of your lower back? Do you have movement restrictions? Do you have lack of flexibility? Are you beginning to get an abnormal posture? Do you have a forward bent back? Do you have hip contractures? Are you stooping forward? Are you experiencing a deteriorating posture? The overview of tonight's talk then will be the disease characteristics of AXPAR and AS. And we will specifically focus on inflammation, the progressiveness of the disease, posture, and chest wall expansion. The treatment options that I'll look at will not focus on medicine because I am not a medical doctor and I don't have enough knowledge to share that with you on medicine, but I will share my knowledge on conservative intervention, specifically physiotherapy. Now, physiotherapists have many tools in our toolkit that we can use as part of our treatment regime in any spinal disease or spinal disorder. But I will specifically focus tonight only on movement and some exercises for specific target areas. Let's start at the normal anatomy. So if you look at this spine, I would like for you to have a background understanding of anatomy. It is my firm belief that if you understand anatomy and physiology, meaning the working of the spine, as well as pathology, meaning something that goes wrong, I believe that you will then be motivated to do the suggestions I make tonight, and that you will be motivated in finding a solution for the problem that you have. So if we look at this overview of anatomy, if you look at the picture on the far left-hand side of your screen, you will see a normal disc. Now, a disc is a soft tissue structure, and it is a gel-like fluid-filled substance. When we have degeneration in the disc, we have a loss of some of that fluid. Now, the main purpose of a disc, it has several functions, but one of the two main functions is shock absorption, like hydraulic brakes of a truck going downhill with a full load. And the other one, it is a spacer. It keeps the space open between vertebrae. And both these functions are very important in axial spondyloarthritis as well as in AS. The next picture there is a bulging disc, which is not the topic tonight, neither is a herniated disc. But what is very relevant for tonight's talk is a thinning disc. Now, when you have any degenerative disc disease or any degeneration like AxSpA or AS, this is what will happen. The disc will lose its fluid-filled content and it will flatten. In other words, it can't be a good shock absorber anymore, and it can also not be a spacer anymore. Now, if this disease progresses, we get disc degeneration with osteophyte formation. Now, osteophyte formation means that it is thickening and densening an overgrown bone, and this would be the body's response to stabilize the segment, because the shock absorption has gone. The disc is not there anymore. And you get this overgrown component of both vertebrae, a vertebrae above the disc and the vertebrae below the disc, and it ends to where these two vertebrae naturally or spontaneously fuse. If we look at this picture in the middle with normal anatomy, those pink structures that looks like marshmallows, those are the normal discs. And if you look in a direct horizontal line towards the back, you'll see these little oval pink areas. One is vertical, one is horizontal. Those are the facet or facet joints. Those are the joints in your back that helps and guides movement. So if everything works well, you have a normal spinal curvature and you will have an upright posture. But when we look at the pathology, in other words, something went wrong of the Ankylosing Spondylite spine, you will notice that those discs are sick. They are diseased. They are inflamed and they are swollen. They are degenerating. And then you will also see that there is degeneration of the facet joints or the facet joints. And that in the end will lead to this loss of normal curvature, leading to the forward stooped posture. And this is one of the things I want to teach you about that tonight. So if we look at what is AxSpA, AxSpA stands for axial spondyloarthritis and AS stands for ankylosing spondylitis. Axial spondyloarthritis is an autoimmune rheumatic disease. It means it's self-attacking, and it's an umbrella term, meaning it is different types of inflammatory arthritis that affects the spine and joints. It is classified as peripheral or axial. Peripheral meaning your joints, such as a shoulder or a hip. Axial meaning spine. It creates calcifications and fibrosis, meaning scarring down and hardening. And this has a result of limited flexibility and limited range of motion. There are two subtypes of AxSpA, non-radiographical and radiographical. Non-radiographical means it cannot, the inflammation and the damage cannot be assessed on an X-ray. Ankylosing spondylitis means that the damage and the inflammation can be assessed on your X-ray. This is very important difference, and this is where the biggest change in recent medicine has taken place. In recent medicine, they have created this NR AxSpA, non-radiographical AxSpA. Why this is very important is patients that met all the criteria for AS, stiff spines, chronic pain, pain improving and stiffness improving with exercise, worsening with rest, patients that had positive BLA-B27 blood test, they met every single criteria except abnormal x-rays. Those patients fell through the cracks because they were not considered as part of this umbrella radiographical or rheumatoid disease group. And they were just sent away. But luckily, we've got this new subtype. And luckily, these patients now qualify under this umbrella and can be treated appropriately. So ankylosing spondylitis, like I just said, can be seen. The changes can be seen on an X-ray. So this is an inflammatory autoimmune disease that starts with the SI joints, and I will explain why. It affects the peripheral joints as well as the axial joints, meaning the spine. And a very important concept of this disease is that it affects soft tissue around the joints. Now, the soft tissue around the joints is specifically ligaments and capsules, also tendons, where tendons insert. So you can see that a wide variety of tissues being affected. If we look at the axial spine, we are specifically focusing on the cervical, thoracic, lumbar, sacrum, and sacroiliac spine. Cervical spine, that is 7 very specific vertebrae. You would be interested to know that a giraffe also has 7 cervical vertebrae in spite of their height. Now, these vertebrae will, when they have a problem, they have a radiating pattern. It radiates pain in a certain pattern. Now, cervical spine can radiate pain into your jaw, into your ear, into your head, headaches, down between your shoulder blades, into both shoulders, into your chest, and down your arms. So it's a whole wide variety of symptoms that you can experience. The thoracic spine have 12 special vertebrae. These are very special vertebrae. You need to remember that every vertebrae has 2 wings to the side and it has a tail in the back. Now, the specialness about the thoracic spine is that it gives the attachments for ribs, and we will talk about that in just a minute. Then we have the lumbar spine. Again, it's 5 very special vertebrae. They are huge vertebrae, and most of you are familiar with low back pain. And then the SI joints. These are noteworthy. If you look at the sacrum, it's this triangular bone between the 2 red areas. The sacrum is the keystone wedge bone that transfers the weight from the upper body to the lower body, and in return from the ground reaction forces up to the upper body. It is a very specialized joint. It is not a true joint. It does not have articular surface area on both ends. One end has articular surface, but the other end has fibrocartilaginous surface. So this is a fibrocartilaginous joint being kept together by a lot of ligaments. And this might be one of the reasons why it is a target area for an autoimmune disease attacking soft tissue. If we look at this picture from the SI joint from the back, all the pink is the ligaments surrounding the SI joint. And you will see that there's a bunch of ligaments supporting it and keeping it together. Now remember that this is an autoimmune inflammatory disease, not only affecting joints, but affecting soft tissue around a joint. And then you can see that it will explain why the SI joints is targeted joints in this area. in this disease specifically. I need to specifically talk about the thoracic spine and the ribs because it is important that you understand that the ribs are attached to the thoracic spine. And because it's attached, it means that there is joints. And because there's joints, it means that ligaments keeps it in place, and that makes it a target area for ankylosing spondylitis and for axSpA. Now, this is a complex area. Every vertebrae connects to the spine through a costovertebral joint, costo meaning the rib, vertebral meaning the body of the vertebrae, a costotransverse joint, which is the rib with the wings of the vertebrae, and as well as the discs of the vertebrae. And then to make it even more complicated, the ribs also articulate in the front with your chest bone. So if there's a problem of stiffening up in between the ribs and the spine, you will have a problem with your lungs because the rib cage contains the lungs. And in order for the lungs to properly ventilate, you need a flexible rib cage. The lungs need to expand when you exercise. It needs to expand when you cough. It needs to expand when you sneeze. It needs to expand when you're sick. So if it cannot do that, it will have grave implications. So the minimum expansion of a thoracic cage would need to be 2 centimeters. The areas of the peripheral joints that are affected by this disease specifically is the hip joints, the ankle joints, shoulder joints, and your Achilles tendon. I'm going to show you a quick video of what axial spondylitis and ankylosing spondylitis is.
In order to understand why spondylosis occurs, it is helpful to know the basic anatomy of the spine. The spine is made up of 33 individual bones, called vertebrae. The spine is divided into 4 sections: cervical, thoracic, lumbar, and sacrum and coccyx. A typical vertebra consists of a vertebral body and a vertebral arch, which has processes for articular and muscular attachment. An intervertebral disc is located between vertebral bodies and protects vertebrae and the spinal cord from the impact of activity. Facet joints are located between each pair of vertebrae. They guide the movement of the spine, providing stability and bearing a share of the load of the spine. Spondylosis is a term used to describe different changes in your spinal joints. It may be caused by aging, degenerative changes, or osteoarthritis. There are 3 general types of spondylosis: cervical, thoracic, and lumbar. The type depends on which spinal region is involved in the pathological process. When joint cartilage breaks down, the space between vertebrae decreases, which creates additional pressure on intervertebral disc. Excessive growth of surrounding bone tissue in form of osteophytes and bone spurs may occur as the body tries to repair itself by building extra bone. Osteophytes and the decrease in space between the vertebrae cause pathological processes involving all structures located between the affected vertebrae, such as facet joints, spinal discs, nerve roots, and the spinal cord. Early symptoms of ankylosing spondylitis can include pain in the spine or in the pelvis, hip pain or stiffness made worse by inactivity, the arthritis in joints, such as the shoulders, hips, knees, and ankles also can go along with ankylosing spondylitis. As the condition progresses, the inflammation of severe ankylosing spondylitis causes the vertebrae to grow together. This leads to ankylosis, which is sometimes referred to as bamboo spine. When the bones of the spine are cemented together, the spine cannot bend, and this results in abnormal posture. Riding in a car, standing or sitting too long may be painful due to sacroiliac joint inflammation.
Okay, so hopefully that gave you a good visual of what this disease entails. Now, I would like to ask you, how would you like to feel? Would you like to dance on the roof with your friends? Would you like to be adventurous? Would you like to just enjoy life? Do you want to be free and run and jump? Would you like to do what you love? Do you want to be creative? Do you want to be an active part of your family life? Do you want to play with your children? Do you want to go out with them? Can you relate to this lady of sleepless nights? One of the symptoms of both AXPAR and AS is sleeplessness. But something can change that. Something besides medicine, and that would be exercise. Hopefully, when you've exercised, it will help you to get some uninterrupted sleep. Sleep is a very important component in ankylosing spondylitis as well as AXPAR because it's an autoimmune disease. When your immune system is affected or when your immune system attacks your body, sleep becomes important. When your body is rested, you have a good and strong immune system. And when your body is not rested or under stress, it affects your immune system negatively. So sleep is a very important component, and sleep hygiene of delaying the progression of ankylosing spondylitis and AXPAR. Inflammation is like a chemical waste product that accumulates on a beach. If you look at this picture, you'll see this, all this wood is debris on a beach. Inflammation is the same in your body. It creates the same. It's just debris in your body. When you exercise though, you have blood that flows in and out and in and out of tissue. And that flowing of blood in and out of tissue creates like currents, almost like when a beach is washed clean by high tide. It removes the chemical waste created by the inflammatory process of this autoimmune disease. So can I encourage you to exercise often and to exercise to where you have a lot of blood flow increase, because it will act like a tide, cleaning your body from the debris caused by the autoimmune disease. But where do you start? It's almost overwhelming. Medicine is very important to take. The medicine that's used in these diseases are cortisone, non-steroidal anti-inflammatory diseases, as medicine, and TNF blockers, or the new immunotherapy. Physiotherapy play a role, and we focus on flexibility, strengthening, postural exercises, breathing, and movement with exercise. The goals of our exercise would be to delay the progression of disease, maintain free movement as long as possible, get chest wall expansion, prevent deformities, and getting some sleep. The focus of what I will show you tonight would be the spine and chest wall with the extremities, upper and lower. There are many types of exercises: swimming, aerobic exercises, and any cardiovascular exercise. We have some controlled indoor exercises, Pilates, the gymnasium, and core strengthening. And if you really like the outdoors, then running and cycling would be good options for you. A few things to keep in mind when you're going to go exercising is stay safe, prevent fatigue. The reason why you want to prevent fatigue is because you're dealing with an autoimmune disease that needs your immune system to be strengthened and not weakened. You need to really focus on your footwear, especially if you're a runner. Reason being, your ankles and Achilles tendons are target tissues for this autoimmune disease. You need to exercise regularly to create that beach effect of the high tide, cleaning the debris of inflammatory waste in your body. You need to stretch those soft tissues that's going to harden and get fibrotic. You need to strengthen muscles to support the column of your spine. You need to focus on your posture and prevent the stooping forward that can create more damage. Core strengthening is obviously a support to the column of your spine as well. And breathing, now you know why, it is to expand your chest wall. Would you like to feel like this, guy? Would you like to have the effects of movement and exercise be a reality in your life? Do you want to have relief of pain? Because exercise can bring that. It can decrease your stiffness. It will slow down the progression of your disease. It will improve the quality of your immune system. You will maintain mobility. You will maintain flexibility. You will have appropriate chest wall expansion, and it will in turn prevent deformities. And something that's not mentioned here, it will also make you sleep better. The next question you're going to ask me is, so what about the dosage? We'll get to the dosage in a minute. Let's first see what the research tells us. The research tells that this exercise is sufficient in the treatment of AS and AxSpA. It also tells us that TNF blockers is very sufficient, and that's the new immunotherapy. So TNF blockers suppresses the immune system, and that's why you feel better. But the best result and the best outcome is doing it together. So the best outcome is not exercise alone or TNF blockers alone. The best outcome is the two combined. Exercise dosage. So how much repetition or how many sets? I don't know. I cannot tell you the answer to that. There is no magic number. It doesn't exist. Because for today and tomorrow, it might be different in your own body, and for your arm and your leg, it might be different. And for different stages and ages, it might be different. So start at the end. What is the goal that you want to achieve? You want to have a reduction in pain, and you want to loosen up tightness. So that's where you're going to start. So you're going to repeat the movements until you achieve your goal. Intensity of exercise is a big question. It is like a traffic light. When you have no pain, when you move or exercise, it is like the green light. You could just go. If you have pain or it's worsening while you exercise, it is easy. You just stop. Orange is a difficult one. If you exercise and it's sore, but it becomes better over time, it's like a green light. You proceed with caution. But if you exercise and it becomes stiffer and more sore, the orange light is now turning red. That means you need to stop. So what I'm going to do here is I'm going to show you a few exercises. Now, there are many exercises. There are thousands and thousands of exercises on internet, on apps. Your physio knows thousands of exercises. There are books of exercises. Your biokineticist knows about exercises. It's impossible for me to give you even the tip of the iceberg. So I've chosen a few exercises that covers a few birds with one stone. I've chosen exercises that will affect more than one joint at the same time. It will affect joint and soft tissue. It will do strengthening and flexibility. It will be functional. I will start with a start position, an end position, and then a short little video clip of the actual movement. So this is a movement for your shoulder joints, for flexibility, mobility, and strength. Sorry about that. We call that flapping your wings. The next one, in our start position, our hands are above our head and it's together. Our end position, you stretch out your arms as far as you possibly can. This will stretch all the tissue in your upper extremity, in your thoracic spine, in your C-spine, in your chest, on your chest wall and your ribs, as well as your shoulders. And you reach out and stretch. Reach out and stretch. Hip, SI joint, and lumbar spine. Your start position is your one foot is against your opposing knee. Your end position is like a figure of four. When you have a stiff hip, you need to be careful you're not to pinch it. This will move your SI joint, your lower lumbar side of your spine on this side, in this case on the right side. It will stretch your knee and it will move your hip joint. Stretch it open and bring it back. Stretch it open and bring it back, and obviously you will repeat this to the other side. Lying on your tummy, this is a hip exercise for mobility. Whenever you want to feed the joint surfaces with synovial fluid, the best movement to do is a rotational movement. Hips is a particularly affected joint by ankylosing spondylitis specifically. Those patients really suffer with hip tightness and stiffness. This is a very safe exercise given that you're not bearing weight, but that you are moving your hips in a rotational fashion. In other words, without weight or loading, you are stimulating the joint, the synovial fluid to produce synovial fluid to lubricate the joint. It will also stretch the tissue on the inside. This is a movement for your spine and specifically your SI joint. The start position is both legs are together. You are diagonally positioned over the bed. Your target leg hangs off of the side of the bed. You're going to lower it down cautiously and you're going to lift it up. Obviously, you're going to repeat this to both sides. Let's look at the neck. Few birds with one stone again. Start position is the double chin. End position is pushing your head back over your shoulders, in this case into the pillowcase. You are strengthening the muscles in the front and the back. You are stretching the muscles in the front and the back. You're giving yourself traction and mobility on your cervical spine. A very good exercise, Simple, excellent for cervical spine issues. A lot of ankylosing spondylitis and AX patients have tight neck rotation. So you have difficulty turning and driving and looking behind you. Start position in neutral, end position as far to the left as you can. Finish that set and that focus on to the left. Then you do start position center, end position to the right. Finish it. Don't do left to right, left to right. You finish one side and then you do the other side. Again, it stretches the one side on the soft tissue and it mobilizes the spine on the other end. One of the reasons why it's so good to do this exercise before you get out of bed in the morning is that your spine will be lubricated, you will loosen up the structures, and it is in a non-weight bearing position. In other words, the discs isn't compressed and the movement is free. When you get to the end, you squeeze a little bit. And again, you repeat it then to the right. Thoracic spine, start position on all fours. End position, with your start position, you have the hand that you chose, the right hand in this instance, coming through underneath. End position, thumb showing to the top, rotating up as far as you possibly can. This is an excellent exercise for thoracic spine mobility, as well as rib cage mobility. Doing it to the left with the left arm. If you have difficulty standing on your hands and knees, this exercise is almost exactly the same as the previous one, except it's in maybe an easier position for older patients. Your start position is on your side, arms out. The end position, you reach as far as you can with your left hand here to touch your fingertips on the one end and then stretch it out to the other end. Obviously, you want to return it to both sides. This will also give you the necessary trunk and rib mobility and extension. With the thoracic spine being the target structure. If you find benefit from the specific exercise, you can do it at the office in standing. Exactly the same like we've just done in the other two exercises. However, you do it in standing, so you can do it at the office. Spinal mobility, when you do it in standing, it will target your C-spine, T-spine, ribs, lumbar spine, and SI joint. So this is the one ring that covered them all. If you've watched Lord of the Rings. Lumbar spinal rotation. Start with both feet together, your knees at 12 o'clock. Rotate out as far as you can to the left, rotate out as far as you can to the right. Pelvic tilt, most of you are familiar with this. Easy way to remember this is pretend that you were a puppy dog and that you had a tail. To do this exercise properly, imagine that you want to put the tail, the tip of the tail, on your nose. So you want to pull your pelvis up, tilting it, not lifting it, tilting it up to where your tail touches your nose. And this is a lumbar and SI joint stretch. A nice lumbar flexibility stretch or a piriformis stretch or a neural tissue stretch. The leg that's on the top is the leg that you're targeting. The leg crosses over and you pull it up to your chest. Obviously, you need to repeat it to the other side. The same position in start and end, like the exercise we have just done. So if it is difficult for you to lift your legs to your chest, maybe because you already have hip joint pathology, a next way to do this would be like this. It's not going to be as efficient or efficient, but it will do. Side bending is one of the movements that's most affected. Those are the movements that happens in that tiny little spinal facet joints. Start position is you hike your hip up as far as you can to the right or the left, and then again to the other side. Few birds of one stone movement again. Start position, focus on your neck, bend it down as far as you can, reach it up as far as you can. And with your thoracic spine and lumbar spine, arching as round as you can, bending as deep as you can. We call this the cat and camel stretch. So there's your neck going up, coming down. Two birds with one stone. It's not just strength or mobility, it's also flexibility. And that's moving all the joints in your spine, your neck joints, your thoracic spine, your ribs, your lumbar spine, and your SI joints. Some stretching, strengthening exercises. Remember, I said that strengthening is important to support the column of the vertebra. Start position on your tummy on the floor. End position, raising your head, your arms, and your legs up. That will strengthen the extensors of the spine, and it will also move your spine into extension, arching in the opposite direction as what ankylosing spondylitis wants you to stoop into. Crossover is exactly the same, except it's not all together, all fours together. It is opposites together. Right arm, left hand, right arm, left leg, left arm, right leg. If you have any scoliotic component to this disorder, especially in AXPAR, then this will be a very good exercise to consider. Same exercise, but on all fours, making it more difficult. The reason is you need to now also use your core stabilizer. So it also adds the core now, and it adds balance. Now, some of you might have noticed, but your balance will be affected by these by the specific autoimmune disease, because a lot of your balance sensors of where the joints is in space, called proprioception, is situated in ligaments, and the ligaments is a target structure. It's affected and it's degenerated and it's hardened. In other words, some of your sensors of where you are in space is affected, making this a good balance exercise, as well as core strengthening exercise. A nice stretch to do in the office every few minutes, at least every 30 minutes. Rotate it as far as you can to the right, rotate it as far as you can to the left, just mobilizing the entire column. Got 3 stretches here. I'm going to play each of them separately. This is the upper back and shoulder stretch. You're sitting right as far as you can, as close as you can to a wall, keeping your lower back, your lumbar spine, your thoracic spine, and your neck against the wall, doing that deep neck flexor exercise that we've done initially, with your neck being pulled back, while you now stretch your arms. And this is a really nice spinal stretch. Straighten it out and come back and lengthen that spine that wants to stoop forward. Again, you can do this at the exercise. You can do this at the office. Most offices have corners. This will stretch the tissue in the front of your shoulder blades or shoulders. It will also stretch your sternum and your ribs. A nice stretch for the office. A nice stretch to do before you start upper body strengthening, or when you're finished. And a low back neural tissue and leg stretch. You're going to grab a hold of your ankles, pull yourself forward so you get a good stretch on your lower back. And then you can extend one knee at a time as if you're walking. And you will feel this pull through the entire system. This is one of the best stretches you can do for all the structures in the back of your spine and your legs. You lean forward and you extend one leg at a time as if you're walking. Good exercise to do before you're going to run or gym or do Pilates. And now for breathing, put your hands against the lower end of your chest wall, against your ribs. What you want to focus on is not to elevate your shoulders when you breathe in, but to rather push against your hands, expanding the bottom tips of your ribs when you inhale to a minimum of a 2 centimeter expansion. Now, let's look at a few testimonials. Phil Donnelly has ankylosing spondylitis, and he realized that he has to reinvent himself. He wasn't a writer, but he's already published 6 books, and the 7th is on its way. Naomi Ban has ankylosing spondylitis, and she was in a very dark place when she realized that exercise is the thing that makes her feel better. And because of that, she wanted to add value to other people's lives by sharing this experience, and she became a personal trainer. And then Amber Panagos, she's a mother with severe progressed ankylosing spondylitis. And Amber says, you just should never give up. You just keep living your life and you keep doing what you need to do. In summary, let's recap the discussion and the importance of what do you need to do in order to decrease the progression of this specific autoimmune disease in your life. You need to curtail the inflammation, and you are going to do that by taking your medicine and by exercising. You need to slow down the progressiveness. You need to correct the postural deficits. You need to increase your chest wall expansion, and you need to curtail fatigue. You need a good night's rest. So how will you do this? You have to take your medicine. You have to have a physician that helps you. You have to exercise. Just do it. Choose the exercises and just do it. You have to move, move, and move. And together with your association, with your physiotherapist, with your friends, with your family, with your physician, with your specialist, with your rheumatologist, together, you will conquer this mountain, and we will all conquer this mountain. I thank you. I'm finished. I do need to thank a few people. Miranda, I need to thank you for inviting me. It is a privilege and it is an honor. I have to thank Emmett Green, who helped me with the slideshow. And I have to thank Maya, my daughter, who was the model. So thank you very much. It was my privilege.
Corne, thank you so much for your lovely presentation. I was actually doing some of the stretches because my video was off while you were talking. That's how awesome it was. I cannot thank you enough, and your beautiful daughter, for taking this time and efforts, for putting this together for us. It was so special. We had a couple of technical glitches, but we will get this video out to everybody. I'm going to turn the recording off, and then I'm going to go into the room if there was anybody that had any questions for you.
Certainly.
To our group, have a lovely evening.